the cardiovascular system changes during the pregnancy. Listen to this and there will always be question from the cardiovascular system changes. What anatomical changes are happening in the pregnancy in the cardiovascular system? Because of the elevated diaphragm and enlarged uterus, the heart will be displaced upward, outward, and there is a slightly left rotation. Okay, so the heart is lifted upwards, outwards, and slight left rotation is there. Clinically, what you get, the apex bit will be shifted. Okay, so what happens to the apex bit? It is shifted to the fourth intercostal space around 2.5 centimeter lateral to the mid clavicular line. Okay, so the apex bit, because there is a rotation of the heart upward and outwards, there is a slight left rotation. That is why the heart bit will be, or the apex bit will be shifted towards left and upwards in the fourth intercostal space you will see, and around 2.5 centimeter lateral to the mid clavicular line. The pulse is slightly increased and there is a occasionally extra systoles. Okay, so what additional findings you see in the heart? You get additional heart sounds and the murmurs. Okay, so there are two murmurs which you should remember. One is a systolic murmur, that is mainly because of the decreased viscosity of the blood, and also the blood vessel become tortuous. That leads to the systolic murmur. So the viscosity of the blood is reduced, the vessels are dilated and tortuous, that will cause the systolic murmur. There is also mammary murmur. This mammary murmur will be along the parasternal or third and fourth intercostal spaces. You will be able to hear because of the increased blood flow in the internal mammary vessels. Sorry, second and third intercostal space, because of the increased flow in the internal mammary vessels. Then you have S3. Okay, that is the third heart sound, which is because of the rapid ventricular filling, and rarely you get a S4. That is mainly because of the atrial contractions. Okay, so S3, which is a third heart sound, that is because of the rapid ventricular filling, you get more common. Then mammary murmur, as I mentioned, it will be heard in the left, second, and third intercostal space. Okay. So if you carry out certain investigations like echocardiography, it will show increase left ventricular and diastolic diameter, increase in the atrial size. ECG will generally be normal. However, it may show left axis deviation. Okay. Now let's see what happens to the cardiac output. Cardiac output begins to rise by around fifth week. Okay. Remember this, fifth week, cardiac output increase. Peak is around 30 to 34 weeks of gestation, and the cardiac output is increased by around 40 to 50%. Okay. So what happens with respect to the different positions? Okay. With respect to the cardiac output, there is a in lateral position, it is highest, while in supine and sitting position, it is lowest. Okay. That is why we always ask the patient to sleep in the left lateral position. In lateral position, you have the highest cardiac output, while supine and sitting position, it is lowest. In labor, there is increase in the cardiac output by around 50%, and immediately postpartum, there is an increase in the cardiac output by around 70%. So mechanism of increased cardiac output is both. Okay. One, there is an increased blood volume. Second, there is an increased metabolic demand. Okay. So oxygen need is also increased. That is why there is a increase in the cardiac output. Okay. The contributing factors are both. That is the stroke volume is also increased and the heart rate is also increased. So that leads to the increased cardiac output. So there are two determinants. Stroke volume, that is the per ml, how much volume is pushed or pumped per beat. Okay, stroke volume. Okay, and heart rate is also increased. That is why cardiac output will be increased. So normally what happens? A normal heart will tolerate this increased load. But if the heart is diseased, that may fail. Okay. Then what are the changes which are happening in the blood pressure? Normally during the pregnancy, systemic vascular resistance is reduced by around 21%. Remember how much is the reduction in the systemic vascular resistance? It's by around 21%. Despite of increase in the cardiac output, the blood pressure will drop down. Okay. Why? Because SVR is reduced. Okay. So blood pressure changes. Diastolic blood pressure will be reduced by around 5 to 10 millimeters of mercury. Mean arterial pressure will be reduced, and systolic blood pressure, there is a minimal change. Okay. So diastolic, generally there is a 5 to 10 millimeters decrease. Okay. Causes of decrease systemic vascular resistance, mainly hormonal, that is progesterone, nitrous oxide, prostaglandins, and atrial natriuretic, okay, ANP. Okay, so these because of this there is a decrease in the SVR. Now what happens to the venous pressure? Venous pressure in the upper body and the lower body will behave differently. In the upper body, it will remain unchanged. When you measure the pressure, the antecubital pressure, the venous pressure will remain unchanged. While in the lower body, the femoral venous pressure is markedly increased. In supine position, there is a 25 centimeter water increase in the venous pressure, while in standing position there is around 80 to 100 centimeter of water which is increased. So femoral pressure is increased markedly in supine position by around 25 centimeter of water, in standing position by around 80 to 100 centimeter of water. And the cause for this is the compression of the iliac veins, and it is more on the right due to the dextro rotation. Okay, so because uterus is rotated to the right, the compression is more on the right side. That is why clinically what you get: edema, varicose veins, hemorrhoids, deep vein thrombosis. These are the effects which you see. Okay. Now coming to the central hemodynamics. Despite of increased volume and cardiac output, CVP will remain unchanged. Mean arterial pressure will remain unchanged or slightly reduced, and pulmonary capillary wedge pressure will also remain unchanged. Okay. And this is mainly because of there is a decrease in the systemic vascular resistance, there is a decrease in the pulmonary vascular resistance, and there is a decreased colloid osmotic pressure. That is why CVP, MAP, and PCWP, that is pulmonary capillary wedge pressure, mean arterial pressure, and central venous pressure will remain unchanged. Okay. Now let's see about the supine hypotension syndrome. This supine hypotension syndrome happens because of the compression of the inferior vena cava by the gravid uterus. The mechanism is there is a decreased venous return, because of which there is a decrease in the cardiac output. Okay, so the clinically what you get: hypotension, tachycardia, syncope. What is the management? There is immediate recovery if the patient, if you turn the patient to the lateral position, the patient will get an immediate relief. Okay, this occurs in around 10% of cases when collateral circulation fails. Okay? Now, regional blood flow changes. What happens to the uterine blood flow? What happens to the blood flow to other organs? That we will see. Normally, the uterine blood flow is around 50 ml per minute. So, in the uterus, near term, it is around 750 ml. So, there is a almost 10 to 15 times increase. Okay, non-pregnant status, it is 50 ml per minute, while near term, it is around 750 ml per minute blood flow. Vasodilatation is due to the progesterone, estrogen, nitrous oxide, prostaglandins, and ANP. So this causes vasodilatation. What happens to the other organ blood flow? Lungs blood flow is increased by around 2500 ml per minute. Kidney blood flow is increased by around 400 ml per minute. Skin and mucosa blood flow is increased by around 500 ml per minute. So clinically you get heat sensation, sweating, nasal congestion, etc. Okay, patient may complain of stuffy nose also. Then what is the vascular responsiveness? Vascular sensitivity is reduced. Okay, there is a decreased sensitivity to the angiotensin 2 and endothelin 1. So that is the protective mechanism against the hypertension. So normally body has got these protective mechanism for protection against the hypertension. But in preeclampsia, this is deranged. Okay, because of the alteration in the vasoconstrictors and the vasodilators. But normally what happens, there is a decreased sensitivity to the angiotensin 2 and endothelin 1, okay, which is a protective mechanism against the hypertension. So what are the hemodynamic changes? What we have discussed, we will just summarize. There is an increase in the cardiac output by around 40%. So 4.5 liter per minute will become 6.26 liter per minute. Stroke volume will be increased by around 27%. That is 65 ml will become 75 ml. Heart rate will be increased by 17%. 70 per minute, it will become 85 per minute. Blood pressure, there is a slight decrease in the diastolic blood pressure. Venous pressure, which is around 10 centimeter, will become 20 to 25 centimeter. There is a 100% increase in the venous pressure. Colloid oncotic pressure will be reduced. SVR will be reduced by around 21%, and peripheral vascular resistance will be reduced by around 34%. So just quickly we will revise. Heart is displaced upward and left. Cardiac output is increased by 40 to 50%. Blood pressure is reduced due to the decrease in the systemic vascular resistance. Pregnancy is high flow and low resistance state. So high flow, high cardiac output is there, flow is high, but the PVR is reduced, SVR is reduced. So there is a low resistance state. Venous pressure is increased, that leads to the edema and varicosities. There is a supine hypotension, which is relieved by the lateral position, and uterine blood flow is increased massively. Okay.